Hello, my colleagues. Let's start our mixed and miscellaneous Viva case. This from now till the October exam, we are trying to simulate the exam exactly from the variation of systems and the variation of degree of case difficulty. This is 11-year-old male patient presented with chest pain. Go on.
Okay. I'm presented with the extra chest frontal projection of an 11-year-old patient who presented with chest pain. I am not able to identify any abnormality in my first glance. So I would like to go through my review areas. The trachea is central. Cardiomediastinal contour is within normal limit. There is a thin air which is seen adjacent to the lung, heart apex, and I would like to know the history if the patient has any associated abdominal pain as well.
He
There
just
is
have
no
trauma.
evidence.
He have
Just have
trauma.
trauma.
Yes.
Okay. So there is air under left hemidiaphragm,
Okay.
and I suspect that it can be due to pneumoperitoneum, subtle pneumoperitoneum. Otherwise, the lung markings, there is normally visualized lung parenchyma. There is no evidence of any blunting of the CP angles. I'm trying to look for ribs. There is no evidence of any rib fracture associated with it. There is no evidence of any sticky air lucences adjacent to the right heart margin. There is no subcutaneous emphysema. I would like to see it in any other view if available. There
Yes,
is
what
no
else?
evidence of. I'm trying to look for pneumothorax. There is no evidence of any pneumothorax, and there is no evidence of subcutaneous emphysema. There is some, like romioclavicular joints are normal, humeral heads are normal. So, sir, I'm not able to identify any abnormality.
Okay. So,
So I would like to advise a lateral abdominal shoot through to confirm my suspicion of pneumoperitoneum, and I would
what
like to
next
take a
step,
history of
doctor?
any
Doctor, what is your next step? I'm waiting for the next step.
CT,
What else?
CT abdomen.
Before CT,
I would like to change the window to confirm
what else? Something
findings.
more primary before the CT. This trauma patient.
This is trauma patient.
Okay. What is the most common cause of pneumoperitoneum in children, post-traumatic children?
Pneumoperitoneum, can be due to duodenal rupture,
Excellent.
and it can be any hollow viscous perforation, any blunt trauma, seatbelt injury trauma, if the patient was in a car, and other possibility can be if the patient has ingested any foreign body, it can lead to puncture and pneumoperitoneum. However, the
No, no,
stomach
see.
outline is normally visualized.
One second. One second. We mentioned that the patient is a traumatic patient. So no need to talk about the foreign body. Correct?
Okay.
Okay. Okay. What else? What will you do next? Please,
Sir,
my
I
colleague, you
will do an
accept
ultrasound.
the candidate in hot seat, please. Yeah. You should tell me something very important.
Sir,
In
there
the
is something more
management.
important.
Yes,
in the management. I would urgently inform the referring physician, and I would like to
yes,
do a.
very important to tell this buzzword. Okay, thank you, doctor, so
Okay.
much. You did very well. It is a difficult observational film. See my colleague, it is very typical to the exam. Startup case, but this is a success or fail case. Very subtle pneumoperitoneum here under the left cubicle of diaphragm. You should pick up it. Why? To ensure that you are safe radiologist. Next step, you will talk about the bones and pneumothorax like this, and you will ask number one to do ultrasound because the patient is still in your radiology department. Ultrasound rule out any free fluid or any solid organ laceration. Number two, I will tell immediately, urgently, the surgical team and recommended for CT abdomen. Doctor, I wanted to ask you, in this case, will you give an oral contrast for the patient or not? Yes or no?
No, water soluble.
Sir, I won't give oral contrast.
You will give
I
or
can
not?
I can give no oral contrast
How come?
because
Why?
it can
Hmm.
uh, because it can lead to peritonitis.
No, no. Think again. Not all oral contrast cause chemical peritonitis. You want to
Then water
assess
soluble?
or yes, water soluble, like Omnipack. So you will give or not?
Okay. I will give water soluble oral contrast.
Excellent.
I,
So my colleagues, in any viscous, in any bowel perforation, you can give water soluble. Why? Number one, sometimes you find the pneumoperitoneum, especially if very subtle, and really you can't pick up the site of perforation. So it will help,
hmm.
very helpful. Number two, it will make sure, you will ensure this is
Hello.
a true
What?
perforated viscous. Okay? But we should not
Okay.
give barium. It will cause chemical peritonitis. Doctor, what is the other common association with the duodenal? You did very well when you told this is a duodenal, most commonly duodenal transaction or injury or perforation. What is the other common association of in traumatic patient presented with duodenal perforation?
Pancreatic laceration and
Excellent.
pancreatitis,
And
or even without pancreatic transaction, there can be associated pancreatitis due to direct trauma to pancreas.
pancreatic laceration. Okay. Uh, so we mean that the site of injury is the epigastric. So what about the vertebrae? There are very common injury, vertebral injury associated with transection of the pancreas or the duodenum.
Yes, it is known as chance fracture of L1. It is mostly
Excellent. What
associated
is
with the seat width.
brilliant? Brilliant. Thank you so much. Discussion like this is very possible. Okay, my colleagues.
Okay.
I was asked about a percent a prognosis of, I think, Ewing sarcoma. The examiner asked me frankly, what is the prognosis? What is the curative percent? Okay.
Okay.
It was a question of a full mark. Okay, but يعني we must be ready for all questions. Thank you so, doctor, so much. Next candidate. So this is a
Thank you, sir.
subtle left subdiaphragmatic air considering pneumoperitoneum for further CT and ultrasound. Next candidate.
السلام عليكم.
عليكم السلام. Doctor, this is 10-year-old female patient presented with upper abdominal pain. Go on.
Okay. Um,
Sorry, I'm unable to scroll.
I will scroll for you. Leave the mouse. Leave.
Okay.
Can you use
These
the
are
bar?
axial sections.
1 second. Can you use the bar? Use the arrow? Use? Or
Sir, 1 minute, I will check.
it's
No,
very
sir,
important.
it's not working.
I will scroll for you.
Yes. Okay.
My colleague, my advice to all of you, if any technical issue has happened, don't panic. Ask the person beside you. Stop the exam, but يعني gently until they repair. Most of the examiner will accept your objection. In one of my Viva, they stopped, they delayed us about 30 minutes to repair some technical errors. And it was very good from them because the candidate before us complained, two candidates complained, so they stopped totally and they postponed our examination about more than, I think, 45 minutes. Okay? Second,
Yes, sir.
don't panic. The examiner at least will يعني in the worst plan will scroll for you. Yeah, doctor, I will scroll and stop me at any slice of importance for you. Go on.
Yes. These are axial sections from CT abdomen post-contrast images, portovenous phase, in which I can appreciate that there is a dilatation of first and second part of duodenum and stomach.
Okay.
There is a lesion noted at the head of pancreas. It is small in size and shows central enhancement. I will check the pre-contrast images as well. It is no significant peripancreatic fat strainings.
اوكي هنا يلا يلا يا أسيف
1 second, please. My
Appreciated.
colleague, please, 1 second. My colleague, mute yourself. This is the fourth time that I ask you, please. This is not acceptable. This is not acceptable. Only the candidate in hot seat is allowed only to talk. Okay, doctor, unmute yourself, please. Hello? Candidate in hot seat, unmute yourself. I believe the mouse. I will.
Yes, sir.
Yeah, okay. Yeah. Let's start again. No pre-contrast, just this axial only. Suppose that the examiner will not give you any other sequences. He will tell you, no, this is enough. Go on.
So there is small. Sir, can you show me again? Sir, I think there is dilatation of stomach and the second part of duodenum. Sir, I will check
Yes.
that this intrapancreatic lesion is either duodenum or it is whether a true lesion. I will check coronal image whether it is annular pancreas or it is a lesion within the head of pancreas.
No coronal sequences images. This is the only available axial images, and the
Okay, sir.
examiner
Sir,
told you this is more than enough.
Sir, I will check its continuity, whether it is continuing with duodenum or not.
Check.
Sir, I think it is duodenal part, so it is annular pancreas. I will check the peripancreatic whether there are any signs of pancreatitis. I will take the measurement of pancreatic head and body as well as tail. Tail, I think, appears edematous. I will check whether there are peripancreatic fat strainings or other signs of pancreatitis. No evidence of any necrosis. Pancreas is enhancing normally with normal vessels passing through it. A normal left renal vein as well as splenic vein noted.
What is the pathogenesis of annular pancreas?
Sir, I will check the serum amylase and lipase level if available.
What is the pathogenesis of annular pancreas? Pathogenesis. What is describe me the pathology? Why is it? How could annular pancreas occur?
Sir, annular pancreas, sir, it is actually a congenital anomaly in which, sir, dorsal and ventral pancreatic ducts, sir, fuses. forming a single pancreas. Sir,
Again,
they
please,
rotate around the
dorsal
duodenum.
and the ventral pancreatic duct. Yes. What happened for them?
Sir, they failure to fuse properly. Sir,
No, but
one
here
part
they are
passes
fused.
anterior
No,
to
no,
the
no.
other.
See.
Yes, sir.
Here
Sir,
they
ये,
are fused.
sir,
What
one
else?
part, sir, I think rotates abnormally and passes anterior to
Excellent.
duodenum, encircles the duodenum.
Which part is the dorsal
Yes.
or the ventral?
Sir, I think ventral.
Excellent. Okay. Could you tell me the parts of the pancreas that formed by the dorsal bud?
Sir, sir, pancreatic part forming from dorsal bud. Sir, I
Yes.
think pancreatic body, tail, and some part of head. And ventral
Excellent. And
bud forms head and uncinate process.
what is the complication of annular pancreas?
Sir, it is a duodenal obstruction or
Excellent.
pancreatitis.
What else? Excellent. Excellent. Okay. Thank you, doctor. You did very well. It is also an observational film. Why? Because see here, not an easy case during the stressful Viva exam. Our colleague did very well. When she sees something here, there are dilatation of the stomach and duodenum. She follow her doubt. Radiology is 50% of your diagnosis sometimes following your doubt. She follow her doubt. She find here something abnormal. At the first, she confused, but she recorrect her situation. Okay. After she saying, oh, there are dilatation here, and the duodenum is within the pancreas head, and this looks like lesion continues with the duodenum, so it looks like annular pancreas. Annular pancreas occur due to failure of rotation of the and ventral bud. The ventral bud, this one, by the way, it is reversed. This is the ventral bud which formed the posterior part of the head. Okay, this one should rotate to come here. Okay, to form the dorsal or the posterior part of the head. Other parts of the pancreas, anterior head, neck, body, and tail. This is the dorsal bud. Very important. So in dorsal agenesis, you can't find tail, neck, body, and the anterior part of the head of the pancreas. Complication, chronic pancreatitis, and obstruction, duodenal and stomach obstruction. So this patient has nausea, vomiting, something like this. Thank you so much, our colleague. Take care of pancreas, especially in old age. Very, very tricky. Thank you so much. Next candidate.
Hello,
Next candidate.
sir. Hello, Assalamu
Uh,
sir. Yes.
Assalamu alaikum. 4 months
Yes.
female patient presented with tachypnea.
Okay. Sir, I'm provided with a chest X-ray frontal projection of pediatric age group. I can appreciate that there is an hypertransradiancy noted along the left lung field, and there is some contralateral shift of the mediastinum is noted. So I can see that the left chest cavity appears to be hyperradiant as well. There is an contralateral vibration. So, sir, I have a few differential. First, I'm suspecting this is a very small child, so I'm suspecting this might be a congenital lobar emphysema with the
Doctor,
contralateral shift.
please, your voice is not clear enough.
Sir, I'm clear
Tell me
right
again.
now?
Yeah,
Yes,
tell me
sir.
again.
I'm clear? Okay,
Yeah.
Sir, this is
Go
the
on.
chest X-ray frontal projection of pediatric age group in which I can appreciate there is the left lung field appear to be transradiant, hyperlucent, and it shows contralateral shift toward the right side. So this is an abnormality is lying in the left chest field. So I'm suspecting this might be a congenital lobar emphysema. I have a few differential. My first differential is congenital lobar emphysema. The diaphragm is seen in place. There is no herniation of stomach or bowel content in the left lung field. And I can see that there's no clear infusion. The mediastinum is shifted toward the right side. No structural abnormality noted. So my first differential is congenital lobar emphysema. Sir.
Okay, what's your differential diagnosis?
Sir, differential could be tension tension pneumothorax can also be the possibility. And also, sir, I was suspecting there's no bowel herniation, so this is not a case of congenital diaphragmatic
Why is this
hernia.
not
So this
tension pneumothorax? Why is this not tension pneumothorax? How could you differentiate between congenital lobar emphysema and tension pneumothorax?
Sir, in pneumothorax, there will no lung marking will be there, but in congenital lumbar emphysema, this few marking should be preserved. It will be reduced, but it not that much disappear.
Again, please, there
And
are
also,
one
sir,
very common sign.
sir, tension, sir, lung marking will not be present in pneumothorax, and there will be visceral sign.
Okay,
We can see the visceral sign. And sir,
visceral,
yes, sir.
what? Yes, visceral.
Yeah, visceral pleura cannot be visible, but in tension
Excellent,
pneumothorax we unable to
excellent.
see
What
visceral
other
pleura.
differential? So we exclude
Sir,
tension pneumothorax. What else?
and sir, other can be congenital airway malformation would also be possibility. Large cystic spaces.
Okay, but okay, what else?
Sir, congenital lobar emphysema. Sir, if baby was little younger, then I also think in the line of foreign body aspiration, but this is a very young child.
Okay, foreign body. Okay, what else?
Congenital sir, CTH.
What
And
about this side? Why
yes,
is the
sir, right
pathology?
side can
Why?
be sir.
See, why you didn't? Which side is the pathological side? Left or right? In this
Sir,
case,
I think sir, this is left lung field.
okay. Why is this not the
Area.
pathological side? Why?
Yes, sir. Sir, another possibility of hypoplastic lung field is also
Yeah,
a
why is
potential.
this? Why is this not hypoplastic?
Sir, I will check the hyla. I can check the vessel size, pulmonary hyla. I can appreciate that the right hyla is preserved, is not that much small. Otherwise, I also think of hypoplastic right lung field.
Okay, why again? The hyla, you're talking about the hyla.
Yes, sir. If it's a sir, if it's a hypoplastic lung, then the hyla will also be small in size.
Excellent.
Yes.
What's your next step or what's your management?
So next, I will go for CT chest to look for the complication and also to exclude other differential. And then this patient require a lobectomy and this requires surgical resection because this
Why
causing
will
compression and respiratory distress.
why are you recommended lobectomy?
Sir, congenital lobar emphysema need lobectomy. This cause compression and respiratory distress to rest of the structures.
And it is a source of infection, maybe a source of infection.
Yes.
Doctor, could you tell me, is this lobar hyperinflation or whole lung? How could you differentiate radiologically? Just lobar or whole lung hyperinflation?
Sir, in lobar inflation, mostly they are left upper lobe, and there's some. I will check the markings on the left lower zone. Maybe some compression atelectatic changes which involve in the lower
Excellent.
zone, and complete it will be entire lobe
Brilliant.
involvement.
Thank you, Doctor. Brilliant. Brilliant. I am asking all the possible questions. Thank you. I will start from the last point. This is just lobar, one loop. This is the apical loop. Why? Because the rest of the left lung, this is the rest, compressed. Okay? See, my colleague, this is herniation of the left lung. This is the left lung. Okay? Could you see my mouse, my colleagues? My mouse is clear? Candidate 2, 3. My mouse, could you see my mouse?
Yes, yeah, yes, sir. I can see clearly your
Okay.
mouse.
So this is the whole left lung. Part of it hyperinflated, part of it compressed and looks like collapsed little bit. So the pathology is here. This one, this is a lobar, congenital lobar. Number 2, why is this not right-sided hypoplasia, aplasia, some sort like this? Number 1, because the hilum is normal. Vessels looks like normal. Number 2, here, not all the lung is hyperinflated, just one lobe. Okay, this is another evidence. Number 3, why is this not a foreign body? Because we didn't, we may include foreign body, by the way, but foreign body will not go through the trachea, and it will go up in the upper bronchus. It is impossible. Look. If this go down, it should either close the whole left bronchus or go to the lower bronchus. Somebody will tell me, doctor, it may be a mucus plug. It's very rare. Very rare. The patient has 4 months. Okay. It may be a possibility, but you should not put this is as a first possibility. Foreign body occluding the left upper lower bronchus. Very rare. Okay, my colleagues, lobectomy is a must. Why? Because it is a source of distress, respiratory stress, source of infection. It is abnormal. It should be rejected. And it may cause later on pulmonary hypertension, my colleague. This is emphysema. And the pulmonary hypertension in neonate or young children is very bad. It will cause a very, very early heart failure. Thank you so much, my colleague. Next candidate.
Assalamu alaikum, sir.
Wassalam. 6-year-old male patient presented with 1-day history of acute abdomen. Could you request control, please?
Sorry, sir, I'm on phone. Can you scroll?
Okay, no problem. 6-year-old male patient presented with history of acute abdomen.
This is CT abdomen photovenous phase of 16-year-old male patient presented with the acute abdominal pain. First, I would like to see the whole images, then I will comment. In which
Stop me at any slice.
yes, yes, sir. Sir, here please stop.
Yes.
There is circumferential thickening of the small bowel lobes.
Okay.
Sir, can you scroll from the top?
To the top.
Okay, once again, please. Yes. I want to check the
Right.
mesenteric vessels actually. Cholecystectomy clips seen in the GB fossa. Likely patient has history of previous cholecystectomy. Mesenteric vessels. Okay.
Don't worry about the mesenteric vessels, doctor.
Okay. Okay. Sir. There is mystery mesentery and congestion of mesentery with marked thickening
Yes.
of the bowel lobes, likely the transverse colon, with associated significant fat standing, and the adjacent small bowel lobes are also slightly thickened. This misty mesentery is encasing the mesenteric vessels, and few
Yes.
small volume lymph nodes are also seen in it.
Yes.
There is no free air is appreciated, but I will confirm on the lung window. There is no free fluid appreciated. Rest of the visualized structures are normal. Urinary bladder, which I see previously, is partially distended with Foley's valve in place. So, in conclusions, it's likely an. Sir, can you scroll it again? So it's likely a case of infective colitis, which is
Could you
involving the
here?
transverse
Please,
colon.
please, could you concentrate here? Here. What is this?
Yes, there is air foci. Air foci is appreciated
Okay.
in the liver,
Okay.
which is peripherally based, likely suggests a photovenous gas. If they are
Again,
centrally
please.
located, then I would think after
See,
pneumopedia.
I will show again. See, I will show you again here. Could you think this is in the liver? This and this.
Sir, it is under the right hemidiaphragm actually.
Okay, so what does it mean?
So it can be a pneumoperitoneum. I would confirm on the lung window.
Okay. What else? Please concentrate in the area of importance. Concentrate again.
Sir,
Concentrate in the
there is diffuse thickening of the bowel loops with
and
significant fat standing.
excellent. And what else? Look here. What else? What is this?
This is also free air, foci of free air.
So what's your diagnosis?
It's likely a perforation of hollow viscus, likely a small
Yes.
bowel, which is
Yes.
causing a pneumoperitoneum, As the patient history is present with acute pain, it's also in favor of this. I would confirm
Excellent.
it on the lung window.
What is the name of this whole viscous? Is this duodenum, ileum? See here, this is the duodenum. Follow it. Follow. This is the
Yes,
fourth
sir.
part. Okay. This upper,
Yes.
left upper is the duodenum. Okay. We are here.
Yes.
Grossly, what is the name of these loops?
Sir, likely these are the jejunal loops.
Excellent. And see the air?
Yes, multiple foci of air adjacent to it, and these are the one of the jejunal loops which get perforated and it markedly thickened.
So give me final diagnosis and management, please.
I would urgently inform the surgical on-call team
Final
for
diagnosis,
the further
please.
jejunal perforation with free air suggests pneumoperitoneum.
Pneumoperitoneum due to what? Perforation of?
Jejunal perforation. Jejunum.
Okay. But the perforation here occur on top of what? See, if you look deeply, you will notice that there are some diverticuli of the duodenum. So this is a
Okay.
diverticulitis, perforated diverticulitis. Okay. Thank you,
Okay,
doctor,
sir.
so much. Take a home
Okay, sir.
message.
Thank you.
It was very difficult case, by the way, and I hide some of the clinical data. First of all, very important, when you are presented with any abdominal case, this is an advice from our great doctor, Dr. Ismail. When you are you are starting from the lower chest. When you are transforming from chest to upper abdomen, this is slice. Check for pneumoprotein. Here, okay? Check here.
Okay, sir.
Okay, my colleague? Very important.
Okay,
This is
okay.
the key. This is the key. This is the most important here. There are foci. Very important. So if we pick up this from the beginning, it will be very easy. What happens in, oh, doctor, I'm searching for يعني grossly. Oh, I find something abnormal here. Don't go through the rest of the examination. Stop here, please. Stop here. Have a look. Go and يعني back until you at least build some idea. It is second bowel, smudge mesentery, and there are some air foci. It looks like either diverticuli, either extraluminal air. I really am not sure. So try to use other plans. Okay. Other planes
Okay,
here
sir.
show it looks like maybe extraluminal, and I have here some pneumoprotein. So if even if you are you didn't pick up or you are not 100% sure this is extraluminal, but really this is extraluminal, so the perforation is here with the inflammation, so it almost diverticulitis of the jejunum complicated by perforation. Okay, don't what you did first, you have a look and you pick up the pathology here. You are excellent. And then you go back, doctor, I want to examine the mesenteric vessel. Okay, very good. But don't shift until you take an idea here. An idea. And it tells the examiner, second small bowel lobe surrounded by inflammatory changes in the form of dirty mesentery or smudged mesentery. It is indicating an inflammatory process. So we are talking about inflammatory process. And what else? Doctor, I have doubt of extraluminal air. Could you transfer or change to lung window? He must transfer. He must in the exam because they used a Baxi
Okay, sir.
system. He must transfer. He will transfer and he will go up and down, up. Doctor, there are some air foci. So this is perforated viscous due to inflammatory changes complicated by pneumoprotein. From the beginning, you will not have to, you are not in need to check the mesenteric vessel. After that, if the examiner have time, tell him, doctor, I will check the rest of the exam. He will tell you no need. Okay, thank you, doctor, so much.
Thank you,
It
sir.
is
Thank you.
it was a difficult case. Don't worry. Next candidate.
Assalamu alaikum, sir.
Salam. Doctor, this is 14-year-old male patient presented with pain. Go on.
I'm sorry, sir.
Can you
Can
scroll?
you repeat the history?
14-year-old male patient presented with pain of the
Sir,
forearm. Go on. Yeah, scroll.
sir, I'm unable to scroll. Yes, I think, is it me scrolling, sir?
Yes.
Sir, sir, I am presented with the MRI forearm. This is, I think, T2 weighted images, in which I can appreciate that there are multiple well-defined, rounded, abnormal signal intensity lesions within the flexor compartment of the forearm. In between the muscle planes, the lesions have well-defined margins and are appearing predominantly iso to hyperintense. And there is the lesions are in the form of a chain along the neurovascular bundle within the intermuscular septa. So I think these are benign lesions. I would like to see these lesions on other sequences as well, like post-contrast sequence.
No post
Sir,
contrast. You can use whatever you want. Any
sir,
sequence from.
First, I will go to the T1 weighted sequence. On T1 weighted sequence, these regions appear iso-intense, and there is no involvement of the underlying bones. The both radius and ulna are normal. And these lesions are causing splaying of the intermuscular fat plane. Sir, on fat sat images, these lesions are appearing hyperintense. To conclude, these are rounded, benign-looking lesions, and no signal void foci or any hypointense areas are seen within these lesions on any sequence. My differential includes neurogenic tumors like neurofibroma or schwannoma. Hemangioma is another possibility, but there is no there is no evidence of any vessels in it on these images. I would like to no post contrast. So most likely these are benign lesions, neurogenic tumors that are in the form of chain, most likely neurofibromas, multiple.
Okay, what is the name
So,
of this sign, doctor?
sir, split fat sign, sir.
No. See,
Sir,
the name of this sign in this slide.
I don't, sir, clearly remember the sign, but they are in the form of chain and along. I
Very
don't clearly remember
characteristic
the sign.
sign. This one. What is the name?
Uh, Sir, I don't remember now.
When you are going to do something, the most important in any project, what is the most important in any project? First issue you do in our life.
Sir, I'm not following you, sir. Sorry.
See,
Sir,
now we have one target to pass the FRCR. This is correct?
sir,
So, what is the name of this sign? Target sign.
target sign,
Okay.
sir. Sir,
Okay. Okay.
sir.
What is your next step?
Sir, I will inform the referring clinician, and because there are multiple neurofibromas, so the patients need to be undergo screening for any neurofibromas in the rest of the body. We can go for a nuclear scan to or we can ask for the history for any other swellings in the rest of the abdomen.
What
And
else?
Sir, biopsy of the lesion to confirm.
No. If I told you this patient has chronic headache, okay?
Sir,
Despite this patient go transferred to pediatric neurology, and
sir,
during examination, the clinician finds that this patient complain of chronic headache. Could you tell
sir,
me
sir,
what headache? Yes.
sir, this condition is associated neurofibromatosis type 1. So it also has intracranial lesions. So we will scan the
Okay.
brain of the patient. We will do an MRI brain to assess for
Okay.
any intracranial lesions, like
Okay.
optic nerve gliomas and other lesions within the brain.
Okay. What other causes of headache in this patient? Number one, you told brain tumors. Okay. Or
Sir,
neurofibroma or optic gloma. Okay.
sir,
Okay. What else?
uh, headache.
Anyone know? What other causes of headache, chronic headache in this patient? Not fuzzy. Fuzzy not
Sir,
cause headache. Okay. 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 What else? What else?
sir,
They are very easy. Non-neurological causes. All our colleagues are writing about neurological causes.
sir.
Non-neurological. Hmm.
Sir,
You can,
this can be skeletal abnormalities are also there in neurofibromatosis patients.
yes, but I'm asking about
Dur
causes of headache outside the CNS.
Sir, dural
Okay.
ectasia is also there,
No, I'm asking about non-neurological causes.
sir. Sir,
There
it is
are
not coming into mind.
two causes. Doctor Amune, could you open your mic, please?
Yes, sir.
Yeah, doctor, how are you? Tell us the answer.
Good. Yes, sir. Sir, I think it could be renal artery stenosis associated with neurofibromatosis that can cause hypertension.
Brilliant. What else can cause, what other association can cause hypertension in F2, in F1? Other causes in the
Sir,
abdomen
I'm
also.
not sure if
In the
I.
abdomen. Do you think free
Coagulation
chromocytoma?
of aorta.
Yes. Candidate 1 mention
Pheochrom-
and Dr. Omer free chromocytoma. Dr. Anagam,
Pheochromocytoma.
Dr. MG, excellent. Excellent for all of you. Thank you so much. Thank you, doctor, so
Thank you, sir.
much. It was a case
Thank you,
of
sir.
multiple peripheral nerve sheath tumor. This is the best answer.
Sir,
Peripheral nerve sheath tumor is the general name of whatever. This is neuroma, fibroma, whatever. Okay, neurofibroma, whatever. This is the general name. But as it is multiple, so it is almost neurofibromatosis. If you see here, what is this also? But it looks
this
like vein. Okay.
vein, sir.
At
Yeah.
least we have three target sign. So this is neurofibroma or peripheral nerve sheath tumor. So we will tell the examiner, we will screening the patient for other feature like number one, brain MRI, and we should enumerate at least 3 or 4, whatever. Number two, in the abdomen, 1, 2, 3. Okay, my colleague. Here, doctor, our candidate, you must tell us about something here other than
Sir, neurovascular bundle.
neurofibromatosis. It is follow the neurovascular bundle. Doctor, why is
Yes,
this
sir.
not lymph nodes?
Sir, it is not the typical location of lymph nodes. Lymph nodes are usually around the elbow and in the axilla.
Okay, what else?
Uh,
I give you
plus,
T1.
sir,
This is T1.
sir,
Why is this not?
sir, there is no fatty hilum, sir, within the
Okay,
lesions.
so the location is not the typical location and no fatty hilum. And also we should talk about the pseudoarthrosis of the fibula. Okay,
Sir,
we will screen the fibula or the leg of the patient for pseudoarthrosis. Thank you so much. Next candidate,
thank you, sir.
welcome.